Started. Ready? Sachin? Good morning, dear students. Today's topic is facial nerve and its disorders. Quite a lengthy topic, but we'll try to see. We'll spend some time and try to understand the facial anatomy and its relations and the various disorders. Okay. Now, basically, we'll go back to the anatomy because that is the basis. So, when we see the facial nerve is a nerve which is the second branchial arch. The first branchial arch being the mandibular, and this is the second branchial branch arch, and this is called the hyoid arch. Now, in each arch, I think there are some nerves related to that, some bones, and also some muscles. Now, if you take up the muscles of facial expression, and along with that, you have the posterior belly of the digastric, the stylohyoid muscle, and also the stapedius muscle. These are the muscles, and the bones are the stapes and the styloid process, and then you have the lesser horn and the body of the hyoid. Okay, so these are the structures in relation to the second branchial arch, which is called the hyoid arch. And this is a very important nerve because this is the nerve through which you can express your feelings, various kinds of feelings that are there in your if you would like to express, and it's very essential, and particularly these days wherein the expression is the most important thing. Now, if you go to the anatomy, there are it's a mixed nerve. It's a mixed nerve. It has got two motor components and two sensory components. Okay, and it is called the queen of face, and also known as nervus facialis. Okay, with this brief introduction, I think we'll go into the subject proper, and that is the embryology, which develops in second pharyngeal arch, that is called the hyoid arch, and the formation of facial nerve begins at third week of embryonic life. Now, then, as I told you, there are two afferent and two efferent. Afferent in the sense the sensory, which come to the central nervous system, and efferent are the ones which go away from the central nervous system. Okay, and if you know, the central nervous system consists of the cerebral hemispheres, the midbrain, the pons, the medulla oblongata, and the spinal cord, and the rest of the nerves which go from there are the peripheral nervous system. Now, in this there are two components, one is the motor, one is the sensory. So, the motor are the ones which are called efferent, which go away from the brain, and they take the orders, whereas the sensory ones are the ones which convey the impulses from the different parts of the body. So we'll go into these, and as I told you, the most important, because this is the one which makes the life dramatic. Okay? Without talking, you can express all your feelings, and this is the general or special visceral efferent. Okay? Then we have the motor, the parasympathetic, which are the which supply the lacrimal gland and also the submandibular and sublingual salivary glands. We'll go into the details of these nerves, how they arise and how they go. And the third nucleus is of course, this is this is again the motor parasympathetic to the submandibular salivary and sublingual glands. And there is small somatic afferent in the sense sensations from the concha, that is the well of the pinna, and also corresponding area on the posterior medial aspect of the pinna, that is supplied by the seventh cranial nerve. And so now we'll try to see the various nuclei that represent the motor nucleus, superior salivatory nucleus, lacrimatory nucleus tractus solitarius. Let's see a diagram and then try to understand where exactly are these situated. As you see in the diagram, you will be able to see the section at the medulla oblongata, the pons, and just try to follow these. Nucleus of the seventh motor nucleus is the one which is represented in the yellow, and this motor nucleus goes backwards and then encircles the pink one, which is the sixth cranial nerve abducens, and then as it passes through passes around the sixth cranial nerve, it produces a small elevation. Okay, in the fourth ventricle, floor of the fourth ventricle, and then it comes forwards and then comes out like that into the pontomedullary junction. It comes to the pontomedullary junction, and then it progresses there and then goes into the internal acoustic meatus. So that is the motor cortex, that is the motor nerve, the nucleus. Then we go to the another nucleus, which is the superior salivatory nucleus, which is represented in the blue here, from which the fibers they travel, and then ultimately they, along with the motor nucleus, they come into the internal acoustic meatus, and along with that you have another tract which is extending from the medulla to the pons to the medulla, okay, which is called the tractus solitarius. Okay, and this tractus solitarius, the fibers from here, the green ones, they also travel along with the facial nerve and then into the internal acoustic meatus. And finally there is a sensory part which is from the well of the concha, and the sensory fibers, they join what is known as the spinal trigeminal nucleus. So now when it comes to the from the cerebellopontine angle and the medullary pontine angle, the components, the parasympathetic, the secretomotor fibers, then the tractus solitarius, which receive the sensation of taste, and the sensation from the general sensation from the ear concha. All three of them together they form a single unit, and then that is called nervus intermedius of Risberg. Okay, and all of them together they travel in the internal acoustic meatus. From there they come out, and let us try to follow how they proceed further. Now, this is another diagram which will also tell us how the connections between the motor nucleus, how the violet one, the motor nucleus, how it goes backwards, and then ultimately it is the one which supplies the muscles of the facial expression. And that's all the various branches that we'll come to later. Then the superior salivatory nucleus, as it comes down through the internal acoustic meatus, then from the geniculate ganglion there is one branch which gets deviated to the lacrimal apparatus, and the second one which travels along and then goes to the submandibular and sublingual glands. We'll try to trace them later. And then these are the connections of these nuclei. Now, the motor, the facial nerve is represented from the cerebral cortex. So the tracts which are going from the cerebral cortex to the facial region, facial nucleus, which is divided into upper and lower. The upper part of the facial nucleus is the one which receives signals from both the lobes, and so whereas the lower is the one which is represented only on one side. So there is a overlapping here on the upper motor neuron lesion, where from the cerebral cortex to the nucleus, which is there in the pons, is called the upper motor neuron, whereas the from the nucleus to the periphery is the lower motor neuron. Then that is as far as the innervation of the face by the upper and the facial nerve, facial representation. Then this is another diagram which will tell us how the four, as I told you, the nervus intermedius of Risberg, which joins the facial nerve, the motor cortex, at the medullary, pontomedullary junction, and then travels towards the internal acoustic meatus. From there it comes into the temporal bone, comes into the temporal bone. Now here the course of this facial nerve is divided as the intracranial part from the nucleus to the internal acoustic meatus. From the internal acoustic meatus, it passes into the mastoid, into the temporal bone. It has got a labyrinthine component. It has then a tympanic component, and after the labyrinthine component, there is a small, there is a swelling which is ganglion, which is called the ganglion, geniculate ganglion, and from where you get a nerve which is the greater superficial petrosal nerve. Now we'll see this greater superficial petrosal nerve there is no synapse here, but it just continues like that. It is the parasympathetic, carrying the parasympathetic fibers. Then at the geniculate ganglion, from there it becomes the tympanic part, the horizontal part of the tympanic membrane, of the medial wall of the middle ear cavity. That is the internal acoustic meatus. Then it comes here, that is the greatest superficial petrosal nerve, and that's the geniculate ganglion. Then it becomes the tympanic part. It has got a horizontal part wherein which runs just above the oval window and below the lateral semicircular canal. Then there it becomes the vertical, that is called the second genome. This is the first genome at the geniculate ganglion, the second genome, and then it becomes the mastoid segment. When it's passing through the mastoid segment, there is it gives off branches. One is the nerve to stapedius muscle, that is the stapedius muscle. Then as it comes down, it gives off another branch which is called the chorda tympani, and this chorda tympani travels in the middle ear cavity and ultimately comes out anteriorly in the petrosquamous suture, and then joins the lingual nerve, travels along the lingual nerve, and then ultimately joins the submandibular salivary submandibular ganglion, which in turn the parasympathetic supply to the submandibular and sublingual glands. Let me show you the diagram of that. Yeah. So this is the one. This is the red one that you see. See, that is the one which continues. This red one is the greater superficial petrosal nerve, which joins, which travels in the middle cranial fossa and then comes out through the foramen lacerum, and where you have the internal carotid artery around which you have the sympathetic chain. The deep petrosal nerve joins this, and together they form the Vidian nerve, and from the Vidian nerve it joins with a zygomatic branch, it joins the lacrimal nerve, which is a branch of the ophthalmic nerve. So, and then ultimately supplies this lacrimal gland. So that is as far as the salivatory nucleus, the parasympathetic fibers to the lacrimal gland, and the continuation like that into the middle ear cavity. From the middle ear cavity it comes out through the petrosquamous suture, joins the lingual nerve, and this lingual nerve travels like that, but it doesn't merge with it, and it forms a ganglion which is called the submandibular ganglion, and thereby supplying the submandibular as well as the salivary, the sublingual salivary glands, sectomotor fibers. So that is as far as the parasympathetic outflow. Then we come to the the motor cortex. We have seen how it travels, and ultimately it gives rise to, comes out through the stylomastoid foramina, and gives rise to the various branches in the face, supplying the muscles of the facial expression, and before it in the mastoid segment, before it comes out through the stylomastoid foramina, it gives off a branch, the postauricular branch, and also branch to the concha of the external ear. Now that is as far as the sensory component is concerned. Now, so there are two motor and two sensory. The sensory is nothing but the chorda tympani which is the one which carries the sensations from the anterior 2/3 of the tongue, the anterior 2/3 of the tongue. The nerve travels along the lingual nerve once again, and then it goes like that and ultimately joins the chordae tympani, and from the chordae tympani it goes to the geniculate ganglion, and then that is how the sensory component is continued. So this is as far as the two motor and two sensory components. Then we go to the, as I told you, there are three important things. The nerve is divided into, which is the intracranial and the intratemporal and the extracranial, as it comes out through the stylomastoid foramina. Then, so the nerve, when it is in relation to the relation to this so we need to understand this, because a lesion which is present in the medulla, the pons, the pontine region at the nuclear level, the lesion also involves the sixth cranial nerve. So you can isolate, you can find out topographically the lesion is present here. Then, as it comes out through the through the pontomedullary junction, it joins these the eighth nerve. It joins the eighth nerve also. So if there is a lesion that is present in the interacoustic meatus, along with the facial nervous intervenous nerve, together when there is a lesion in the interacoustic meatus, there is the facial nerve, there is the eighth nerve involvement is also present in conditions like the acoustic neuromas. Then the intratemporal, the intracranial part is the one which is not covered by the perineurium. So it is covered by thin layer of the pia mater, and so it is likely that this is the area where it can get irritated and give rise to certain conditions which we will discuss later. Then we go into the this is the facial nerve as it emerges out through the stylomastoid foramina, and the pes anserinus, the various temporal, zygomatic, buccal, marginal mandibular, and the cervical branches are there. And all of them supply the muscles of this facial expression, which are the subcutaneous muscles. Now, the blood supply of these the facial nerve is the anterior inferior cerebral artery, the labyrinthine artery, and the superficial petrosal artery, and the stylomastoid artery. These are the various arteries which supply the facial nerve. Then, with this brief background, we will come to the nerve structure proper. Now, the unit of the nerve is is a single nerve which contains nucleus, the cell body which contains the nucleus, the mitochondria. Then it has got the dendrites. Then you have the axon, which is covered by the myelin sheath, and in between there are spaces which are called nodes of Ranvier, and then ultimately the axon terminals. And when the nerve is stimulated, there is a wave of depolarization that travels along the nerve, and then ultimately it ends up, and these terminals are the ones which either unite with another nerve, or sometimes they are innervated into a gland. So they are innervated into a muscle. So these are the nerve endings which may get attached to another nerve, to the muscles or the various glands, and through which a neurotransmitter is the one which is released from this, which is called the acetylcholine, which in turn is neutralized by normally presenting deactivation by acetylcholinesterase. Okay? So this is the general action of a nerve cell, single unit. Now this single unit, the nerve cell, is if you look into this in a complex, in a nerve, it is covered by endoneurium. Endoneurium is the first layer which covers the axons. Then these together they form a bundle, and they are in turn covered by another sheath which is called the perineurium, and these form the fascicles of the bundles, and such bundles once again they are together bounded by another tough layer which is called the epineurium. The endoneurium is the one which maintains the nutrition for these nerves, and you have these blood vessels which supply the nerve. So this is the basic unit of the nerve cell and the various components. So the endoneurium, the perineurium, and the epineurium. Then with this small background, we will go into the various injuries that the nerve suffers and how we classify these. These are classified by one classification which is called the Seddon's classification, where the axon is the one which is the flow of the axon is to some extent blocked because of the pressure. Okay, and that is called neuropraxia. There is the myelin sheath is intact, only the axon, even it is not damaged, but there is a small compression, there is small decrease in the flow, so the nerve conduction becomes slow. This will recover usually in 2-3 days. It's highly temporary. The second one is the axonotmesis, wherein there is a damage to a small segment of the axon, and beyond this discontinuity, usually Wallerian degeneration occurs, and slowly, because the myelin sheath is intact, the axon slowly re-establishes itself, and then the function regains, but this may take about 3 months' time. This is called axonotmesis. Then the third one is the total section of the nerve, which is called neurotmesis, wherein the myelin sheath along with the axon is totally, completely destroyed, and there is a gap in between. This is called neurotmesis, where there is a total block of the conduction, and the distal one undergoes the Wallerian degeneration occurs, and depending on the gap that is there, the regeneration may occur, or it may form a neuroma. That is as far as this Seddon's classification is concerned. There is another classification which is more practical, which is by the Sunderland classification. The first degree neuropraxia. Neuropraxia, initially, as we have discussed, there is the epineurium, the endoneurium, perineurium, and endoneurium. Okay. Now, in the first degree of neuropraxia, there is mild compression, there is no axon degeneration, and usually this is the small indentation there, and so this will recover within 24 hours. Type 2, wherein there is a moderate compression and there is a block of the flow of the axon, and so there it forms complete block of the conduction, and this is the one, and here the endoneurium, the perineurium are intact, and so there is a chance for this to recover, and it may take about 1 week's time. There is a third, a little more severe compression, where there is a segmental demyelination, and in such conditions where it may take about 1 to 2 months. Then you have the second degree of degeneration, where the axon injury is there with degeneration, and the epineurium, perineurium, endoneurium are intact, and so there is always chance for the nerve to recover, but this may take roughly 2 to 4 months. Then we go to the third degree of degeneration, wherein there is a severe compression not only in the axon but also in the endoneurium is damaged. So when this damaged endoneurium is there, it becomes fibrosed, and this will block the further regeneration of the axon, and so leading to a neuroma. So the recovery in these conditions is never complete, because there is a scar tissue that has formed and a neuroma has occurred. Then you have the fourth degree, when there is a traction, compression injury, the chemical injury, various kinds of injuries, where the epineurium intact, but the axon with the endoneurium and perineurium are damaged. Okay? Only the epineurium is intact, whereas the endoneurium and the perineurium are damaged, and so such conditions, the recovery is not totally, it won't be there, which requires surgical procedure. Then you have the fifth degree, where there is a severe disruption, there is a tissue loss, there is a gap between the cut ends of the nerve, where all the layers are disrupted, and so where there is a gap between, and the gap cannot be bridged, and so it carries a very poor prognosis, and micro reconstruction surgery is the one which is indicated in such conditions. Now these are the various types of nerve injuries that have been described. Then we come to the various disturbances or various clinical signs and symptoms that a facial nerve damage can result in. One is the weakness of the facial muscles, because they are the ones which supply the muscles of facial expression. The total flaccidity, paralysis. Then you have the loss of control of the orbicularis oculi. So there is a dribbling of saliva, and you cannot close the mouth, so there is always a leak when you are drinking water. And along with that, you have the pain if it is inflammatory condition, and the facial asymmetry, and then the loss of taste, because the chordae tympani is there, which takes impulses from the anterior 2/3 of the tongue. There is hyperacusis, because the stapedius tendon, stapedius muscle is paralyzed, and so the function of the stapedius, as you know, is to prevent the loud sound vibrations traveling into the inner ear by just pulling the neck so that the footplate of the tape is turned away from the scala vestibuli, and so the sounds are dampened. But here, because of the loss of this muscle activity, there is hyperacusis. There will be vesicles, and the facial pain, decreased salivation because sectomotor fibers are also sectioned, and decreased tear secretion. Once again, there is a damage to the parasympathetic fibers which travel to the lacrimal gland. So these are the various presentations, disturbances, and the facial paralysis is usually classified as the central and the supranuclear, wherein upper motor neural lesion, as I told you, from the cerebral cortex to the nucleus is called the upper motor neuron lesion. From the nucleus, the intracranial part, the intratemporal part, and then you have the intratympanic part, intramastoid part, and extracranial are the ones wherein there is a lower motor neuron lesion. Now we'll try to study some of these conditions. Generally, you can classify or you can study them in the central. You have the brain abscess, pontine gliomas, poliomyelitis. The intracranial, the acoustic pneumas, meningiomas. Congenital, you have the cholesteatoma. The intratemporal are usually divided into idiopathic, infections, trauma, neoplasms. The extracranial, malignancy of parotid, surgery of the parotid, and neonatal facial injuries during the forceps deliveries, and systemic diseases, diabetes, hypothyroidism, uremia, and polyarthritis nodosa. Now the intratemporal are the ones where the traumatic, maybe trauma, the head injury, or it may be a surgical trauma when you are doing a stapedectomy, or when you are doing a mastoidectomy, or the cholesteatoma surgeries. Then the classification, one of the classification by House and Brackman, it says normal function grade 1, grade 2 is mild dysfunction, grade 3 moderate dysfunction, and grade 4 moderately severe dysfunction, and grade 5 is severe dysfunction asymmetry, and the sixth one is the total paralysis, complete absence of tone or the motion. Now we will try to discuss some of the common conditions which affect the facial nerve, out of which the Bell's palsy is the one. Now this was described by the Sir Charles Bell. There is another Bell whom we know, that is the Graham Bell, who invented this telephone. Now this is Charles Bell, and he has studied the facial anatomy extensively, and concluded ultimately, he said, this is a very important nerve. It is called as the respiratory nerve of face, and demonstrated separation of motor and sensory innervations of face. Now by definition, an idiopathic paresis or paralysis of the facial nerve of sudden onset. This is what a Bell's palsy is. And the most common cause is the facial paralysis. 15 to 40% of cases. Both sexes are equally affected, and diabetics are more prone. There is a family history, and mostly unilateral. Then if you go into the etiology, the exact etiology is not known, that means idiopathic. There are various other conditions which are incriminated, like the autoimmune response, the viral hypothesis, ischemic hypothesis, wherein factors which produce vasospasm, the cold, the temperature, anoxia, injury, toxicity, and allergies. These are the various etiological factors. The signs and symptoms are sudden onset, unable to close the eyes, Bell's phenomena, wherein the eyeballs roll up and out on looking up. the attempting to close the eye when you are trying to close the eye, and this white sclera is visible. This is called Bell's phenomenon. Then you have the dribbling of saliva because orbicularis oculi, oris muscle, orbicularis oris muscle is not competent. There is epiphora because once again there is orbicularis oculi is not proper, and the lower eyelid is the one which doesn't, the eyelid doesn't meet, so the puncta doesn't come in contact with the lacrimal secretion, and so it doesn't drain into the nasolacrimal duct. It just comes out, which is called from the lower lid, and comes onto the face, which is called epiphora. Then of course the asymmetry of the face, noise intolerance once again because of this stapedial paralysis, and loss of taste, the chorda tympani involvement, unable to smile, and drooping of corners of the. These are the various signs and symptoms related to that. Now we come to another condition where it is called the Ramsay-Hunt syndrome, herpes zoster oticus. The chickenpox virus gets activated at a later life and gives rise to small vesicles in the external part of the pinna, the concha, that is the well, where the nerve supply, the facial nerve sensory component is present. Then it is usually the facial nerve paralysis, and the pain, the vesicles, is something which will make us a diagnosis of Ramsay-Hunt syndrome. Then we go to another syndrome which is called Melkerson-Rosenthal syndrome, wherein the patient will have swelling of both the lips along with the facial nerve paralysis, and the tongue is fissured. You can see the fissures of the tongue. And there is another condition which is congenital, not a very common condition, but still it is called M.B.B.S syndrome, wherein the child will have sixth and seventh nerve paralysis occurs. Then we have another condition wherein Guillain-Barré syndrome, as we know, it's a inflammatory demyelinating polyneuropathy which is affecting the myelin sheath, and so the facial nerve can also get infected in this. Then we mentioned about the traumatic causes, where there is a fracture of the temporal bone, and there are two kinds of fractures that are described. One is the longitudinal, and that is the longitudinal, and the transverse. So usually the transverse signs are the ones which wherein you'll have the facial nerve injuries, and these injuries you have to find out whether there is an immediate facial nerve palsy, or it was a little delayed palsy. If it is a delayed palsy, we can wait and see, but if it's immediate, it requires the surgical intervention wherein you try to isolate the nerve and then remove the bone chips which are pressing on the nerve. Now you have the transient facial palsies, wherein the dental surgeon is trying to inject the local anesthetic to give local anesthesia for the dental extraction, or sometimes when we do a tympanoplasty or wherein we inject orally, there will be it's a temporary phenomenon, paralysis of the facial nerve, which usually recovers once the local anesthetic effect wears off. Usually 2 to 3 hours, during which the eye has to be protected. Now there are certain hyperkinetic disorders which are described. There are two things. One is the hemifacial spasm, where one side of the face, there is a closure and deviation of the facial nerve. So it's called facial twitches, and these are usually because of the irritation of the nerve at the cerebellopontine angle. Okay. And second one is the blepharospasm, where there is a orbicularis oculi on both sides they go into some kind of a spasms. Okay. And the treatment is the injection, microvascular decompression in the hemifacial spasm, or the botulinum injections. Then we come to the diagnosis of the facial nerve. There is certain, basically by the careful examination of the history taking, wherein the onset of duration, degree of recovery, acute or it has been slow progressing, sudden onset neoplasms, and trauma, history of trauma, or there is a trauma and a delayed onset, and the otological examination to give us whether there is a cholesteatoma or a infection present in the ear. That is about the various examinations, and in addition to that, you have the examination of the face to find the involvement of these the muscles of facial expression, the frontal, then the orbicularis oculi muscles, where patient is asked to close. There is blowing, wherein you hold the air in the and blow the cheeks, and this is the teeth being shown. So these are the various tests in order to find out whether it's a facial weakness or paralysis. Then you have other diagnostic tests which are called the shimmer test, which will tell us about the amount of secretion, lacrimal secretion. Usually when there is a facial nerve palsy, there will be a decreased lacrimation, and so usually that means there is a lesion at the geniculate ganglion where greater superficial petrosal nerve comes out. Then you have the stapedius reflex, where the stapedius nerve to stapedius comes in the middle ear cavity. So any injury proximal to that, there will be a stapedius muscle contraction, which can be tested by impedance audiometry, wherein in 69% of facial palsy is absent. Then you have the electrogustometry, that is to measure the amount of taste, sensation, and the electrical stimulus is applied onto the tongue, and the stimulated chorda tympani electrode attached to the tongue, and current passed till the patient feels a metallic or sour taste. This is to establish the chorda tympani continuation. Then you have the submandibular salivary flow test, wherein the submandibular salivary glands are the submandibular salivary gland ducts are the ones which are cannulated, and the difference, 25% reduction in one side, is significant to say that there is a facial paralysis, which is the parasympathetic fibers are not coming to the submandibular ganglia. Then you have the electromyography, which record the spontaneous voluntary muscle potentials by needle electrodes introduced into the muscle. Records the potentials, and it will give us whether the muscles are active, and this will help us in assessing the re-innervation after 2 weeks. And then we go to the another test, which is called electroneurography, wherein this is most reliable test for us to see the amount of or assess the amount of damage of the facial nerve, the most accurate prognostic test. The objective is the qualitative measurement of the neural degeneration. The nerve is stimulated with impulse using a bipolar electrodes placed on either side of the nose and the forehead. Then the electrical stimulator placed in front of the ear and recordings obtained in computer. Peak-to-peak amplitude intact axons, two sides compared, and reduction in amplitude 10%. That means it's a poor prognosis. So electroneurography is another important test. Then you have the nerve excitability tests, which are called Hinges test, which are commonly used. The minimum threshold that is required to elicit a twitch or which is visible in the muscle, that is the one which is seen. The placement of stimulating electrode at the stylomastid foramina. A difference between 3.5 milliamperes is poor prognosis. That means the nerve is degenerated. Then you have the maximum stimulation test, where it's a modification of nerve excitability test. The same equipment, the maximum stimulus is applied on affected site, on the unaffected site, and the same stimulus is applied on the affected side. If there is no response, that means decompression is the only option, that is the surgery. Then you have the CT scans and the MRIs, which will to some extent guide us about the various kinds of tumors that are present, which can compress the facial nerve at various levels. Then the complications of this facial nerve. Usually when there is an incomplete recovery, there is a facial asymmetry which is persisting. The eye cannot close completely, and so there is the epiphora which is continuing. And because of the oral sphincter which is weak, the drooling and of saliva continues. And when drinking water, the water comes out through the mouth. So that is one incomplete recovery. Then you have exposure keratitis, which is the most important complication, which has to be carefully managed. That is, when there is an opening of the eye, and the eye is exposed, exposure keratitis occurs, and corneal ulcers occur, and they can give rise to blindness. There is also a decrease in the production of the tears, and so the exposure keratitis is a major problem which has to be taken care. Then of course the synkinesis, mass movements when patient wishes to close the eye, the corner of the mouth also twitches, and this is because there is a cross innervation of fibers as the fibers develop. There is no treatment for this. Then you have the tics and spasms result in faulty regeneration once again. When the nerve is injured, different nerves which were stimulating different muscles, they are innervated, and so there are involuntary mass movements that usually occur. Then you have these contractures. The fibrosis occurs because as the nerve is degenerated, the muscles slowly undergo fibrosis, and they are the ones which atrophy. So this affects the movement of the face. Then there is a condition called crocodile tears, which is called gustatory lacrimation. That is, when the patient is eating, he gets the tears in his eyes. This is once again because the parasympathetic fibers which were supplying the submandibular salivary gland now supply the lacrimal gland instead of the salivary glands. And so there is when the patient is chewing, there are these, the lacrimation is produced. And this can be treated by suctioning of the superficial petrosal nerve, which is coming out from the geniculate ganglion. Then you have the phrase syndrome, gustatory sweating, which is usually seen in conditions where there is a superficial periodictomy that's done, wherein the secretomotor fibers of the parotid gland are inserted into the sweat glands of the skin. And so when the patient is eating something, there will be sweating of the face, the skin around above the parotid gland. And of course, along with this, the kind of psychological and social problems that can arise because of the deformities. Then the treatment is based on the amount, the kind of trauma or the trauma that occurs to the nerve, and the extent of the damage. Now, depending on that, there are two kinds of treatment. One is the medical treatment, where you have the physiotherapy in case of Bell's palsy, then so that the muscle atrophy doesn't occur, you do the massage and exercises. Then within 2 to 3 weeks, you can put the patient on prednisolone immediately, and then slowly tapering. Vitamin B1, B6, B12 and antivirals are also administered. And then we come, if they are not recovering, the various tests that are being done will tell us whether there is a the grading of the nerve damage. And so if it is grade 3, 4, 5 and 6, the surgical management would be the treatment of choice. Now here, the surgical management would be, if there is a fracture, then the fracture line has to be identified, and the nerve where there is a damage, you should try to take out the bony chips which compress the nerve and produce this complication. And neurorrhaphy is nothing but when there is a clear-cut section of the nerve, the two ends are sutured, that is neurorrhaphy. And nerve transfers are done when there is a deficient. So this is what is done, facial nerve decompression, where there is a narrow space there, and then that is widened. And second one is the neurorrhaphy, as I told you, is when there is a complete section of the nerve, the two ends are sutured by 90 or 80 nylon monofilament. Then the nerve grafting. Nerve grafting is done in conditions where the gap is more than 1 centimeter. Okay, so the various nerves that are used are the hypoglossal nerve, the sural nerve, great auricular nerve, and sometimes the branches of the cervical plexus. These are used as grafts, which are placed in between the proximal and the distal end. Then you have the cross facial nerve grafting, where from one facial nerve from one side are grafted to the other, the paralyzed facial nerve, and so that gives rise to the movement of the muscles of facial expression on the paralyzed side. Then you have these nerve transfers, like the facial hypoglossal transfers. Okay, and then you have the surgical management. The temporalis muscle is the one which is split, and the muscle, part of the muscle, is introduced into the upper and lower eyelids, then to the angle of the mouth. Okay, so when there is this is a masticatory muscle. So when you close the mouth, there is a closure of the eye, and also the angle of the mouth is pulled up. So this is the temporalis muscle transposition. Then you have the tarsorrhaphy, either medial or lateral tarsorrhaphy, to reduce the space between the eyes, the eyelids, upper and lower eyelids, so that there is the damage to the cornea is reduced or minimized. Then you have the gold and platinum lid weights are placed into the small surgical incision is made in the upper lid, and these processes are placed into the eyelid, so that by the weight, they usually close the eyes, and then the facial reanimation results are good. The sling operation that has been performed by the temporalis muscle, and those are the results which are fairly acceptable. So this is an extensive topic wherein we have dealt with the various nuclei of the facial nerve, the tract, the two motor and two sensory components, afferent and efferent, and how they supply the lacrimal and the parasympathetic, the submandibular and sublingual, how the motor cortex, the nerve supplies the various muscles of second arch. Then you have the general sensory, which is at the concha of the ear. And the various lesions that are related to that, and how you make a diagnosis, and ultimately how you treat the various disorders of the facial nerve. Thank you.
You said 17 or 4 members ఉన్నారు, అందులో 2 members మేమిద్దరమే చూస్తున్నాం.